Our lecture today is about Class 2 Division 1 Malocclusion. So as usual, start with the definition. Class 2 Division 1 is where the lower incisor edge lie posterior or palatal to the cingulum plateau of the upper incisors, while the upper incisors are proclined or average inclination and the overjet is increased. These three things has to be there in the definition to be a Class 2 Division 1. Sometimes we have increased overjet and the lower incisors are posterior to the cingulum plateau, but the teeth are upright. We call these ones our Class 2 intermediate, where we have increased overjet and the upper incisors are upright. However, sometimes we get the upper incisors are proclined, where the one side is proclined and the other side is retroclined, and they are posterior to the cingulum plateau. In this case, we call it Class 2 indefinite because we can't define it. It could be Class 1, it could be Class 2 Division 1, or could be Class 2 Division 2. Angles classification, as again, that is depending on the molar relationship, which basically the mesobuccal cusp of the upper six is anterior to the buccal groove or the mesobuccal groove of the lower six. Sometimes you find a definition that it's a distal buccal cusp of the upper six, including with the mesobuccal groove of the lower six. Features and etiology. So sometimes I like to join these together, because when you say feature, this is how the malocclusion and at the same time could be the etiology. For example, if you say it's Class 2 skeletal, the patients who have a Class 2 Division 1, so it's a feature and at the same time it could be the cause of this malocclusion. So again, when we discuss features and etiology of the malocclusion, we look at the skeletal, soft tissue and dental factor. We'll start with the skeletal, and again we have anteroposterior, vertical and transverse. So whenever you have a patient who's a Class 2, you are expecting him to have a Class 2 skeletal as well. And usually the cause of this Class 2 skeletal is a retrognathic mandible. But however, it could be prognathic maxilla. Now, it's quite unusual to have a prognathic maxilla as a cause of the Class 2 skeletal. Usually it's the mandible. How to diagnose this in the clinic? One way to do it is to drop what we call it the zero meridian line, which is basically a line that we drop it from nasien perpendicular to the Frankfurt plane, and the chin should be sitting on this line. If the chin is sitting posterior to this line, that means that the mandible is retrognathic. A quite good trick that I like it in the clinic, you simply ask the patient to posture the mandible forward. So after posturing the mandible forward, if he has a straight nice profile, then that means that the mandible is retrognathic. If after posturing the mandible forward you find that everything is prognathic, everything is protruded, the patient now is bimaxillary protrusion, then the maxilla is the cause of the problem. Usually these patients has increased cranial base angle. So we have the anterior cranial base, we have the posterior cranial base, and this is the angle between them. Now, the mandible is attached through the glenoid fossa to the posterior cranial base, while the maxilla is attached to the anterior cranial base. So if the angle is increased, it means that the mandible will be set more posterior, resulted in a retrognathic mandible. So the mandible could be a right size, but it's positioned posteriorly due to the increase in the cranial base angle. Usually these patients as well, they have a longer cranial base. But do we see Class 2 Division 1 malocclusion only in a Class 2 skeletal patient? The answer is no. It depends. Sometimes you have a patient who's a Class 1 skeletal, but we have a habit, like thumb sucking habit. We can have like a lip trap that resulted in increase in the overjet, proclination of the upper incisor, and the patient, as in this photograph, will have Class 2 Division 1 on a skeletal 1 malocclusion. Also, a local factor, as we're going to see later, can cause this kind of problems. If patient has a missing teeth in the lower arch, the overjet will be increased, although the skeletal relationship is normal. But the usual thing that you have typical Class 2 skeletal with retrognathic mandible resulted in an increase in the overjet. So what about the vertical relationship? We can have both. We can have an anterior growth rotation and we can have a posterior growth rotation. However, as you see, when we have an anterior growth rotation, it means that the chin is moving more forward, which kind of reduces the severity of the class 2 skeletal. And on top of that, usually patients with anterior growth rotation respond better to the treatment with functional appliance, class 2 elastics, because all of these are extrusive mechanics. So when we have a reduced lower facial height, anterior growth rotation, that will help us that the patient will take this extrusive forces. So in a class 2 division 1, we prefer patients who has anterior growth rotation, although we can see patients who has a posterior growth rotation, which we have an incomplete overbite anteriorly or even open bite. These patients are really difficult to manage because first this mandible is going back, making the class 2 more severe, and also any treatment we do, usually it's an extrusive mechanic resulting in reduction of the overbite, and also we know that functional appliance respond better with anterior growth rotation patients. So we can have both of them. Transverse problem is not quite an issue in a class 2 skeletal patient or a class 2 division 1. Most of patients are symmetrical, or there was no clinically significant asymmetry. I like this terminology more. What about soft tissue? Now, we expect to have patient who has a class 2 skeletal or increased overjet that the lips will struggle to meet together. So this depends on many factors, depends on the amount and the severity of the class 2 skeletal, depending on the lower anterior facial height, whether or not the lips can meet together. So in this case, for example, you can see that the lips are meeting easily, and there is no tension here in the mentalis muscles, which means that the patient has competent lips, which is great. However, sometimes the patient will not be able to have a competent lips. These lips can't meet. But we know for sure that patients, in order to swallow food, we must have an anterior oral seal. So if the lips are competent, then this is easy. They're meeting together anteriorly, they are having anterior oral seal, we swallow the food, no problem. But what's going to happen if the patient has an incompetent lips? First, the patient will stretch the mentalis muscle, stretch the muscle that's surrounding the oral cavity to bring the two lips together, either by stretching the mentalis muscle or even posturing the mandible forward so the lips can meet together. How we can diagnose that in the clinic? We simply look at the mentalis muscles and the labiomental fold, and we see that become shallow and the mentalis muscle is stretched is active, as we can see here, that there is an activity in the mentalis muscle to bring the two lips together. Or that the lip become trapped behind the upper incisors, as we can see here, touching the palate. We call it lip to the palate anterior oral seal. So basically the lip become trapped behind the upper incisors, touching the palate, achieving anterior oral seal. If we have this kind of malocclusion, imagine that the lips is here. So what's going to happen, it's going to push the lower incisors posteriorly, causing retroclination of the lower incisors, and it will push the upper incisors anteriorly, causing an increase in the overjet. So whenever we have a lip trap, you're not expecting an overjet less than 8 to 9 millimeter, which is the thickness of the lower lip. So in these cases, lower lip and the lips, they are working against us. They are making the malocclusion more severe than what it looks like. And that's why I mentioned before, if we have, for example, a mild class 2 skeletal or even class 1, and the patient might have, for one reason or another, a lip trap, then the upper incisor will be proclined, the lower incisor retroclined, and will have an increased overjet. Now, generally speaking, we see a lip trap in the patients with increased overjet and reduced lower anterior facial height, because it will be easier for the patient to bring the lips behind the incisors because this distance is reduced. So simply the lip become trapped, and there's already a minimal or like an increased overjet that will get worse once we have a lip trap. So here, a patient with anterior growth rotation with this increased overjet, he will have a lip trap. While a patient like this who has a posterior growth rotation, usually the patient either posturing the mandible forward and then bring the two lips together, or he will force the lips to meet together, or number 3, we call it tongue thrust. The tongue will move, or tongue to the lower lip, achieve anterior oral seal. So the tongue will just jump above the lower incisors, trying to reach the lower lip to do anterior oral seal. Now, if we have a situation like this, we will have anterior open bite, and the lower incisor will become proclined as well. However, it's always been a debate whether the tongue is the cause of the problem or it's just an adaptive position to the anterior open bite. So the patient usually achieve anterior oral seal either by lower lip to the palate, or we call it lip trap as well, or the lower lip to the tongue, the patients with increased vertical dimension causing an anterior open bite, or stretching the mentalis muscle or forward posturing with the mandible to bring the lips together. What about dental and local factor? So usually you are expecting, whenever you have an increased overjet like this, that the teeth will try to compensate. So usually the lower incisors are proclined, trying to do dental-alveolar compensation. And by definition, overjet is increased. The interincisal angle usually is reduced, because by definition again, upper incisors could be average or proclined. And the lower incisors, they are trying to compensate, so they move forward. They are proclined as well. That's why the interincisal angle will be reduced. We expect, if the patient is a class 2 skeletal, class 2 division 1 incisors, is everything in the upper arch is pushed forward, the buccal segment will be a class 2. Now, because the upper teeth are moved forward more than the lower teeth has no stop. The lower teeth, they have no teeth to occlude or to bite with. So what's going to happen, that these lower incisors will over-erupt. They will either over-erupt to the point that they will touch the palate and can probably cause trauma, or they just over-erupt and then they stop without causing any trauma. Okay, so either way we will have an increased curve of SPE due to this over-eruption. Now, because we have an increased overbite, increased curve of SPE, we are expecting to have a deep overbite in a class 2 cases. However, the exception for that, when the patient is doing the adaptive tongue swallowing, or the adaptive tongue thrust, or the adaptive anterior oral seal, well, the tongue will jump above the lower incisors to reach the lower lip to achieve anterior oral seal. In these cases, we will have a reduced incomplete overbite. However, remember, whenever you examine a class 2 patient, class 2 division 1, make sure that the patient having his mandible in the right position, because these patients tend to mask the severity of the class 2 by posturing the mandible forward, which can give us during examination a misleading information. Local factor as well, if we have a crowding, so the teeth will try to align, but then they push themselves to the outer circle to try to create space for these two to erupt. So sometimes this kind of movement of the upper incisors further forward will result in a class 2 division 1. If you look at this patient, extraorally he look fine, he's a class 1, then look intraorally, huge overjet. So why is that? If you do a proper counting of the teeth, you're going to see that he has a missing one central incisor, or one incisor. So when he is missing an incisor, the teeth are retroclined to close this space, resulting in increased overjet and class 2 division 1 incisor relationship. Habits as well can cause a class 2 division 1 incisors relationship. So if you have the tongue, the thumb between the upper and lower teeth, it will procline the upper incisors and it will retrocline the lower incisors, causing an increase in the overjet and a class 2 division 1 malocclusion, as we can see this diagram. So what is the management? What are we going to do with a class 2 division 1 patient? Treatment options, and these treatment options are mostly similar for different kind of malocclusion. Accept is always an option, and growth modification option number 2, camouflage is option number 3, and orthognathic surgery is the last option. So when do we accept this malocclusion? If the patient has no complaint, if there is no issues, cause for example crossbite with displacement that needs treatment, then the patient can, if he's happy with the way the teeth look, then he don't have to go for treatment. Now option number 2 is to do a functional appliance, and for assuming growth modification. So you have an increased overjet like this, and then you fit the patient with functional appliance to try to reduce this overjet. So this has always been a dilemma when to start this kind of functional appliance treatment, and we covered this topic in details when we covered the functional appliance, but just quickly, we know that early treatment was proposed to achieve more skeletal correction, improve self-esteem, reduce risk of trauma, and then the evidence came up that no skeletal improvement or no more growth we get if we start an early treatment. However, trauma and psychology could be improved. So the most effective way to start now class 2 growth modification is adolescent growth spurt, when the patient in the adolescent growth spurt. However, because we know that from the evidence that most of the effect that we get dental alveolar, some of authors recommended that we start the orthodontic treatment at the late mixed dentition, early permanent dentition, because at that time the teeth are about to exfoliate the last tooth, usually the E, so you can use the leeway space, you can correct the overjet, and then you can immediately transfer the treatment to the fixed appliance from the functional appliance, because by the time you finish the functional appliance treatment, patient will have all the permanent dentition, so that will reduce the treatment time. So this is just a quick summary where early treatment is justified, as we mentioned, if there is a trauma, risk of trauma, self-esteem that will be improved, and if the patients get polyed because of teeth, you can't allow him to wait. So if you have a patient, for example, like this, who has a massive overjet, incompetent lip, usually these people are risk of trauma, because anything gonna hit the patient's face is gonna hit the teeth. So maybe an early treatment is good for this patient, and definitely if they get bullied and teased in school. Just remember when you plan your treatment that the mandible tends to grow forward more than the maxilla during the adolescent stage, which is in the most of our patients are this age, which provide us a correction for the class 2. So usually whenever you have a patient who has a class 2 skeletal and he's still at the age of 13, 14, even 15, that means he's still growing, and this growth is working with us, not against us, which is gonna help us to correct the malocclusion. However, again, if you're going to stick to the thing that we will start the treatment in the late mixed dentition, early permanent dentition, you need to know that, or remember that the girls mature considerably earlier than boys, which means by the time we start the treatment for them at the early permanent dentition, late mixed dentition, most of the girls will have finished their growth spurt, while the boys not. So that's kind of something to consider, that we will have more growth to be expected with the boys. So when using functional appliance, we fit the patient with twin block, MOA, medium opening activator, fixed functional as well can work, that will aim to posture the mandible forward and then reducing the overjet, as we can see, and this is lateral open bite as a side effect of using twin block. And then you go to the second stage of fixed appliance, where the overjet now is reduced by the functional appliance. You continue the treatment where you close the spaces. Now, to correct class 2 malocclusion, headgear can be used as well as a functional appliance or orthopedic appliance. How does it work? The whole philosophy that the headgear will hold the maxilla, so it will allow everything else to grow but the maxilla. So now the correction, the malocclusion will be corrected, and the molar relationship will be corrected from class 2 into class 1. However, we should know that usually patient who has a class 2 skeletal relationship, they will have a class 2 molar. And how that happened, because the molars in a class 2 situation, they will simply rotate into a full unity class 2. Doing just the rotation of these molars will kind of improve the molar relationship, and that's what happens in most of the cases in which you use headgear. Just once you insert the headgear, the molars will derotate and they will be improving into almost class 1 molar relationship because of this derotation. Definitely it depends when we started, if we're going to finish in a class 1 or not, but at least class 2 will improve, class 2 molars will improve just by the derotation. So when you're using a headgear for orthopedic force to just hold the maxilla, restrain the maxilla, you're going to expect that the derotation of the molar will take place. We will get more dental space to correct the class 2 molar relationship. For a cooperative patient whose lower incisors are already proclined, so we can't procline them more, headgear to restrain the maxillary growth can be a good option for treatment. So that was growth modification. What about camouflage treatment? Now, the key point to do a camouflage is to try, well, the definition of the camouflage is that you are trying to mask the underlying skeletal discrepancy. So when you have a patient with a class 2, you need the first question to ask you, what is your concern? So if the patient concern is his profile or her profile, then the only option that we can do for this patient is orthognathic surgery. Now then, if the patient has no concern for his profile, like for example this one, then we can start thinking, okay, what is the best for him? How I'm going to do the treatment to improve his profile? But imagine if the patient, she's not, she doesn't want to go for surgery like this patient, and her malocclusion is severe. So these patients we have to be careful with, because you offer them surgery and they said no, and then what are you going to do? For example, this patient, obviously she has a class 2 skeletal, increased overjet. If you go and extract 2 premolars and retract them, the nasolabial angle will be tremendously increased, especially that the patient has a thin lip, so you're going to make her profile look worse. So in these patients, you need to be careful. Any treatment planned should be guaranteed that it will not worsen the patient's profile, or at least it will improve it to make the patient look better after we finish treatment. So what are the favorable features for orthodontic treatment alone if there is no dentoalveolar compensation? So if a patient has a class 2, you are expecting that the upper incisors try to retrocline while the lower incisors they try to procline. So if the beginning of the treatment the lower incisors are proclined and excessively proclined, then there is nothing you can do for this patient and he has to go for surgery. The difference in the A and B is not high, like you don't get an A and B of 7 and 8. However, whenever you consider an A and B, you should consider the faults of the lateral cave and the errors that we have. Definitely, if we have a growing patient, is much better than a non-grower, because remember that the maxilla finishes earlier than the mandible will keep growing, helping to correct the class 2 malocclusion. And definitely if we have a habit, if the patient stopped the habit. Now, and this is here very important and need to focus on. Now, whenever we have a class 2 malocclusion, meaning class 2 buccal segment relationship, we have 3 methods to correct this class 2 into class 1 or either into a full unit class 2. These methods are distal movement of the upper molars, differential anteroposterior tooth movement using the extraction space, and extraction treatment that consists primarily of forward movement of the lower arch, which is a non-extraction treatment. So whenever you have a study model in the clinic doing treatment planning or in the exam in the future, we all know that the canine should finish in a class 1. Your molars should finish either in a class 1 or in a full unit class 2. So whenever you see something like this, you stop and think of one of the 3 methods that we mentioned: distalization, extraction, or non-extraction treatment involving mesial movement of the lower arch. We'll discuss them one by one. We'll start with distal movement of the molars. Now, if you think about distal movement or mesial movement, which one is easier than the other, you will come to the conclusion that definitely distal movement is more difficult, because it's more backed area. There is a lot of things there. There is the second molar, there is the third molar, there is the tuberosity, the bone. So it's not easy to push the tooth distally. While mesializing the tooth, you're just proclining the upper incisor, is much easier than distalization. For that reason, whenever you do distalization, you will expect that we will have anchorage loss in the form of proclination of the upper incisors, because mesialization is much easier than distalization as a tooth movement. And don't forget to add on top of that that you are distalizing the biggest teeth in the arch, 6s and 7s. They are much bigger than the central incisors and the lateral incisors. So when should we do distalization? When is the best timing to do distalization? It is recommended to be done just before the eruption of the second molar, because that will give you more space and less anchorage demand to distalize the molar. And there's a guy called Carlson in 2005. He did a randomized clinical trial testing the jigs and the headgear, and it was 2 samples. In one of them the second molar was there, and the other sample the second molar was not there. What he noticed that when the second molar was not there, the distalization was 3 mm, while when the second molar was there, the distalization was 2.2. And not only that, the anchorage loss is more. The anchorage loss is less when the second molar is not erupted yet. So here the proclination of the upper incisors was only 0.8. Proclination, don't forget, it represents anchorage loss because you're pushing the molars distally. The reactionary force is pushing the incisors forward. So in the first group, which is basically the one the 7 has not erupted yet, the molars was distalized 3 mm, and the upper incisors, in the group that there is no second molar, the molar was distalized by 3 mm, and anchorage loss in the form of proclination was 0.8, while in the group the 7s erupted will have less distalization by 2.2 and more anchorage loss by 1.8. So almost here as if nothing has happened. So it's very important to decide planning the distalization earlier than the eruption of the 7. That definitely if you are using the conventional mechanics, as we're gonna see later. So however, whenever you do distalization, there's 2 things that you need to consider. That's something to treat with caution, or maybe you can consider it as a contraindication, which basically if you have a thin labial buccal bone, because you are pushing the teeth into a wider parts in the maxilla, which a little bit, if they have a thin bone, you might end up kicking the teeth outside the bone. The other thing is patient with a high angle and anterior open bite. So if you distalize the teeth, you are moving closer to the hinge axis of the condyle, which means that you will have more posterior growth rotation, and you will have further increase in the maxillary mandibular plane angle and on the overbite. So whenever you have a patient with increased lower facial height or anterior open bite, try to avoid doing distalization, or if you insist on doing distalization, do distalization with intrusion to make sure that you don't incorporate any extrusion of the molars. So how can we do distalization? First option is headgear. So basically you get a patient, fit a headgear, this is the straps, this is a high ball headgear, this is the face bow, transferring the force into the 6s, moving them posteriorly. But the problem with the headgear, that patient can't go like this to the school. Patient will never wield the headgear 24 hours. It's really hard to do that. And as we know from the physiology and the biology of tooth movement, that we need a continuous light force to achieve orthodontic tooth movement. So this is a huge disadvantage of using the headgear to distalize the molars. Plus on top of that, imagine if you use the headgear, you distalize the molar for 12 hours, then the patient stop wearing the headgear, so the molars will move forward until they are engaged with the headgear on the second day to distalize them. So sometimes what happens, you distalize, you stop wearing the headgear for the day, in the night the patient wears it again, the headgear, the molar has moved forward. So that's all of the limitation of the headgear. However, for the headgear to be effective in distalization, according to the evidence, the patient should still have their vertical growth potential and elongation. How is that? So when the teeth are elongated and over-erupted due that the vertical growth is still going, it will be easy at that time that the headgear will distalize and tip these teeth posteriorly. As long as they are over-erupting, it's easier to tip them distally. For that reason, high ball headgear is not as efficient as cervical ball headgear in doing distalization. The second thing that you need to have, as everything else with the conventional techniques and distalization, that you must have the second molar either has not erupted yet or extracted to use the headgear for distalization, and to have a vertical growth of the maxilla of the dentition. Don't forget that patient with the class 2 skeletal will have a rotated molar. Once you insert the headgear, this rotation will be corrected, giving us more space to correct the maloclusion. So how much distalization can the headgear do? Again, Bondmark in 2005 randomized clinical trial. He found that the headgear is able to distalize by 1.7 millimeter, and the 7s have not erupted yet. Well, is it a lot? Not really, but this is what we got when you use a headgear. So the other option to do distalization is nudger appliance. So we discussed when we talked about the headgear that the patient can't wear the headgear all the time, and that if the patient take the headgear off, the molars will move forward. So they came up with the idea of, okay, let's use nudger appliance, in which basically we have a south end clasp on the incisors, Adam's clasp on the premolar, and then the palatal finger spring. Now here, just to make sure that the idea of using the palatal finger spring is not to do the distalization. The idea of the palatal finger spring here is to help the headgear with the distalization, to hold the molar when the headgear is not being worn by the patient. So now you get that light force still going on that can still do the distalization, and also it would not allow the molar to drift forward. So this is the whole idea of using nudger appliance. But if you use nudger appliance by itself without using a headgear, once you push the molars forward, which is first bigger than the incisors, and second, you are pushing them into an area that is difficult to move. You have second molar, you have molars, you have a smaller tuberosity. As a result, once you push the 6s, the reactionary force will push the incisors forward, resulting in an increase in the overjet and anchorage loss. So as you can see here, this is the design of the nudger appliance after we finished. So here the distalization of the 6s, enough space is created. Then again, another appliance to hold these 6s posteriorly and distalize the premolars before going to the fixed appliance treatment. However, if you look here, you can see that all the premolars and the 6s are tipped distally, because simply with the removable appliance we are not able to do a bodily movement, we do tipping movement. So now all the teeth are kind of tipped distally, and this is one of the major disadvantage of using the nudger appliance, that excessive tipping on the molar will need a brightening later on, and also there will be an excessive anchorage loss. How is that happening? First, you distalize the molar. So distalizing the molar is anchorage demanding if the patient did not wear the headgear. So distalizing the molars, patients wearing the headgear is doing most of the job, fine, we are good. But patient is not wearing the headgear as she should be. Now the palatal finger spring is trying to, because they are slightly activated, pushing the molars distally, we will have a reactionary force that will procline the incisors, and it will result in increased overjet and anchorage loss for us. The other way of having anchorage loss, now to distalize the molar is one thing, and then to use this space to reduce the overjet is another thing. So what you need to do after distalization, you need to hold the molars where they are so you can bring the incisors posteriorly to take this space. As we do with the extraction decision, we prefer to extract the first premolar if we have an anterior crowding or increased overjet where we need most of the space anteriorly. And if we don't need a lot of space, we go to a posterior space or posterior extraction. It's the same here. You will do distalization, so we get most of the space posteriorly. So we need to reinforce anchorage to bring these teeth back. Then again, patient goes for the second stage of fixed appliance treatment, finishes everything in the class 1 because it's a non-extraction case. So the question now, is nudger effective? Now, Paul in 2002, he did a randomized clinical trial which randomized patients into nudger appliance and Jones jig. And by the way, Jones jig is just like a spring in which it pushed the teeth distally. And they found that nudger appliance is able to do distalization by 1.3 millimeter plus minus 1.3. So it could be 0, that means, or it could be 2.6, the amount of distalization, and that's the maximum amount we can get. However, 7s were erupted in this study, so that means it could kind of reduce the accuracy of this study, because we know for a fact that distalization is much easier if 7s has not erupted. And if you're gonna go now to the clinic to do distalization using nudger, you must know that you need to use a headgear. 7s should not erupted. Is that all for distalization? No, we can use something, you call it class 2 elastics with a sliding jig. So when the beginning of using elastics, they used to believe that heavy elastics will do distalization of the incisors and less than a proclination on the lower. However, after superimposing on the lateral cave and clinical examination, they found back in the 1950s that all what they were doing is a proclination of the lower incisors. From here came up the idea of using the sliding jig. So what is the sliding jig? So basically you have this arm going up here, and then you use the class 2 elastics. So you are focusing and concentrating the force into the molar. By that, what's going to happen, this molar is going to move back and move distally, and the space will open up distal mesial to the canine, and the canine relationship and the molar will be converted from class 2 into a class 1. Having said that, and using the idea of the sliding jig, still mesial movement of the lower incisor is still possible. And you can't use a sliding jig and you think that all you're going to do is distalization and ignore the fact that the class 2 elastics is running to the mandible, causing a little bit of proclination and mesial movement of the lower incisors. So another option of distalization is pendulum appliance. So first of all, pendulum appliance gets its anchorage from the palate using the acrylic pad that we see here that engaging the palatal surface. And then you get these two wires that made of TMA, not stainless steel, TMA wire, because these TMA wire are more flexible, giving less force applied to the teeth. And then you squeeze this one, closing the loop, and make it engaging a slot in the mad lingually, as we can see here. And then you bond these kind of arms into the molars to stabilize the appliance. So what's going to happen is that you are pushing the molars forward posteriorly, and the reactionary force, in theory, should be coming to this acrylic pad that will hit the palate, and no anchorage loss. It's working kind of like an ants in the opposite way. The acrylic is here, preventing the molars from pushing forward the incisors and stabilizing them and forcing them to go posteriorly. So is the pendulum the perfect appliance? Number one, it's no, because of this acrylic pad. Now it's bonded, so it's fixed to the teeth. So cleaning underneath this pad is not as easy as we think. So you're going to have a lot of gingival irritation and inflammation due to this acrylic pad. The other thing is, when you distalize, there's a huge amount of anchorage loss. Remember that here we don't use headgear. We rely on the palate to reduce the amount of anchorage loss. So we could have an anchorage loss. And the most important part, even if we don't have an anchorage loss, once we distalize the teeth, again, we need to hold these molars where they are and then bring the incisors. So again, to distalize is one thing, and to hold these molars in their place to then distalize the up anterior teeth is another thing, because that's a very difficult situation, because you are talking about a fraction of millimeters. You're talking about, for example, distalizing the molar 2 millimeter, 2 to 3 millimeter. So you're not allowed to afford, or you don't afford to lose space by mesial movement of the posterior teeth, because all the space you got is 2 to 3 millimeter. You need all that space for the anterior teeth. So here, this is from Prophet textbook. The candide distalization is happened. Molar canine is in the right place to erupt. So, whoa, distalization is excellent. Oh no, not yet, not really. When you do a superimposition, they found that net distalization of the molar relative to the maxilla was minimal, and that most of the correction happened due to the jaw growth, transverse expansion that is done to create space for the molar, and the forward movement of the lower incisors due to class 2 elastics, rather than distalization of the buccal segment. So again, is pendulum effective? Follow-up studies with pendulum appliance showed that space obtained by pushing the molars back with it was largely lost during later space closure, to the point that overjet reduction often was disappointing using the pendulum appliance. So if you decided to use the pendulum, you just need to know the limitation and the results of the pendulum. So now to go to the technology, skeletal anchorage. The first one is to use a mini plate. So you insert the plates into the infrazygomatic process, and then you insert the endozygomatic arch, and then you insert the mini plates there, and you hold the teeth and to do distalization. It's a good option but the only issue with that it needs a surgical procedure to place the zygomatic, to place the mini plate. The other option is to place what we call it the alveolar implant, like this. So here, if we want to do distalization of these molars, you insert the TADs here, which is, we call it alveolar implant because it's inserted in the alveolus, and you hold this TAD to the bracket and you use a push coil. So the push coil now will hit the 5 to move the 5 forward, which can't be done because it's tied to the TAD, but the only option is that all the forces from this push coil will go to the 6s and 7, pushing them posteriorly. So as you can see here, enough amount of space is created. But now again, the same problem that we have with using nodger or using pendulum appliance. Now we created the space, we need to hold the molars where they are to allow the post-anterior teeth to move forward. And here what we did is we took the implant from the buccal side and we placed it in the palatal side to hold the molar where they are to prevent the space loss. So you can see now this is the amount of distalization we achieved. So you don't want, if you're using a power chain to retract the canine without anchorage here, all what's going to happen that this molar will move forward taking all the space that we created. So what we did is we removed the TAD from the buccal side, place it in the palatal side to hold the molars. And this is a huge disadvantage of using alveolar TADs in distalization. Now, a new systems became available. One of the most famous one is the benefit system, in which they're using palatal TADs. Now, we said alveolar TAD, that is in the buccal side, in the alveolus. We said about the mini plates in the zygoma, and now we're talking about the palatal TADs. Now, palatal TADs are successful TADs because of the thickness of the cortical bone and the attached mucosa. Now, we know that the most important factor in the success of the TAD is having enough thickness of cortical bone around the implant. If you have a bigger implant with a bigger diameter, you get more cortical bone. So if you're using TADs in the palatal side or in the buccal side, in the palatal TADs, you have more cortical bone. You can use bigger diameter because there is no roots that you will be worried to hit. So for that reason, palatal TADs become more popular. And as you can see here, this is one of the appliances which do distalization. So this appliance, you have to squeeze this coil, and then you have this knot that you fix it to the wire, and this one will push the tooth distally. And as you can see, it is placed at the level of the trifurcation of the molar, that to achieve bodily movement and to reduce the chances of a tipping movement. So this one here is for mesialization. That's video from the website of the company. Just ignore this one and focus on this one. This one for mesialization. This one distalization. The coil is not closed, they just move the molar forward. So you can do unilateral distalization with this appliance, and you can do bilateral distalization. So the TAD will be inserted into the palate. Have this appliance, they have the bar here that will engage the 6. And as you can see, the force is at the level of the trifurcation, which will reduce the first disadvantage of the other conventional method of distalization. That is, we're going to get tipping movement of the molars instead of a bodily movement. So now using this appliance will get more bodily movement. Now when you're using skeletal anchorage, the amount of distalization that was done is improved compared to the one that we used when we used to use headgear or nodger appliance or pendulum appliance, to the point that when you do distalization, you might cause impaction of the third molar. So here there is 3 schools to deal with that. The first school say extract the third molar. So you do easy distalization, you should be fine. But then they came up to another school. There will be extraction of this third molar, especially if you are talking about an adolescent who is 15 years old, will be more traumatic. So why not to extract the second molar, as we can see in this radiograph, and then allow the 8 to take the place of the second molar. So simply you extract the second molar, you do distalization, take half of the space, and then the 8 will come down and take this space. Now, the disadvantage of this technique, that first you need to take a molar, and I'm not sure if the parents will be happy to take out such a big tooth. And also, do you guarantee that this molar, the third molar, will come down and take the place? Most of the cases, yes, but you can't guarantee 100%. And you get, now we said we have different schools, two of them, we mentioned them, one to go for extraction of the 8, one of them extraction of the 7, the other one just do non-extraction. What they believe is that, okay, 8 is impacted, just do distalization, you're gonna go with it, you're gonna distalize, and then the 8 will become impacted. Well, yeah, that's an option, but again, if this has happened, 8 become impacted, and in the future, if a cyst developed around this 8, the extraction will be a very traumatic procedure. Again, is distalization using TAD efficient? Well, there is many studies now on the TAD and distalization. Just one of them showed it's a different technique, that it goes 3.3 distalization, and there's a huge variation again, and it goes 1.8 of intrusion, which is good, because we need intrusion to overcome the problem of extrusion, or the problem of the hinging effect when we move the molar more distally. So to summarize up, let's look at these points. Little or no distal movement of the upper molar is produced by class 2 elastics. So remember that when you are using class 2 elastics, distalization that you get, if you're gonna get any, is very minimal, because it's easier for the lower jaw to move forward. So you get more of mesial movement of the lower jaw rather than distalization. It is difficult to distalize the upper teeth too much with the headgear or palatal anchorage like pendulum, nudger. It's really not easy thing to do. Skeletal anchorage, however, they are really effective, to the point that even when you're using a skeletal anchorage to distalize the teeth, you can create enough space to the point that you might end up over retracting the incisors. So this is the first method of correcting class 2 malocclusion. What is the second method? It's basically differential anteroposterior tooth movement using extraction spaces. So how is that? So basically you get the teeth out to reduce the overjet. Now the more you have crowding, which means the more space you need to correct crowding, and then you need space to correct the anteroposterior relationship. So this case will become more complicated, and you need to plan your anchorage correctly. So let's say it again. If you have a patient with increased overjet who has a well-aligned dentition, then the space that you need for treatment of the malocclusion, extraction to retract the incisors only. But if you have increased overjet and crowding, so the extraction space is needed to relieve the crowding and to reduce the overjet, which means that the anchorage demand will become higher. So the treatment can be done by extraction in the upper arch only and retraction of the upper incisors. In this case, we are agreeing to finish in a fully united class 2 molar relationship. And the other option is to go with the extraction in the upper arch and in the lower arch at the same time, to limit the amount of proclination in the lower incisor, or to relieve crowding in the lower arch. So we know that we want more movement, more posterior movement of the upper teeth backward, while in the lower arch, all what we want for the extraction now is just to relieve the crowding. We don't want these incisors to go back. So our anchorage demand in the lower is lower. Actually, we don't need these incisors to move back. For that reason, we take out, if we decided to take out teeth in the lower arch, the lower 5s, and in the upper arch, we take upper 4s. So again, usually we go for the extraction in the upper arch just to retract these incisors. However, sometimes if you don't want to procline your lower incisors and you have crowding in the lower arch, you just simply extract the 5s, not the 4s. Again, if you do this and use class 2 elastics, that will result in distalization of the canine, making use of most of the space, but in the same time it will move the molar into the extraction space, and it will not do any proclination of the lower incisors because there's an extraction space here. So the class 2 elastics will help you to close the space in the way that you want, which basically moving the anterior segment, upper anterior segment posteriorly, and the lower posterior segment anteriorly. So why to go for extraction in the lower arch? Again, not to procline the lower incisors. So why we don't want to procline the lower incisors? It's because of stability. We don't want to change the intercanine width. Is that evidence-based? Well, the answer is no. There's no difference in stability between the cases treated by extraction of 2 premolars or extraction of 4 premolars. So to make your life easier, whenever you have a class 2, that's a again, that's an advice according to my personal experience. Whenever you have a patient with a class 2, think twice before you decide to go for the lower arch extraction, because that's going to make your life much easier managing your anchorage, especially if you end up with do space closure, the lower incisors moving posteriorly. So far we managed to say about distalization, differential extraction in the upper and lower arch. The last method is using non-extraction treatment using class 2 elastics. I like this diagram. So this is a superimposition of lateral cuff of a patient treated with the class 2 elastics using to correct the overjet. Now the black color is the before treatment, while the red color is after treatment. So if you can see here that we did get a little bit of let's say distal movement of the upper anterior teeth, because this is where we started and this is at the end of the treatment. So a little bit moved distally. Now in the upper arch, because of the molars actually moved forward, or at least in the same place, no distalization. But in the lower arch, look amount of proclination of the lower incisors that we got. It's a lot of proclination. So when you have an increased overjet and you're using class 2 elastics, you immediately think that, okay, a little bit of distalization or distal tipping of the incisors, and a lot of mesial movement of the lower incisors and proclination. Now, to limit the amount of the tipping movement, you should use rectangular wire in the lower arch to prevent free tipping of the incisors. And as we know, MBT brackets is the best when it comes to class 2 cases. And why is that? Because if you're using class 2 elastics as here, these teeth tend to be retroclined. And again, because we have the slope and the play between the arch wire and the bracket, you will expecting not to get the correct amount of torque. For that reason, you don't need the incisors to be tipped when you finish the treatment, so you have a higher torque in the upper incisors, and that's why MBT is good here with a positive 17 torque of the incisors. However, in the lower arch, we do proclination of the lower incisors, and you don't want the incisors to be tipped and excessively proclined. You want them to be upright at the end of the treatment. So if you're using the bracket with a torque of 0, you're not going to get 0 because of the play between the wire and the bracket. And that's why we use MBT, which is -6, and that's give you 0 at the end. And that's why MBT bracket was manufactured actually, and the prescription was for a class 2 patient. Remember, whenever you're going to use a class 2 elastics, you should use it in rectangular wire, especially in the lower arch, to prevent excessive proclination of the lower incisors. The amount of the force should be 250 grams per side. And that's how you need to use this number when you measure the amount of the force that you need, and you measure the type of the elastics that we're going to use in the clinic. So again, 250 grams per side. Now, incorporating the lower molar into the appliance, attaching the elastics to the mesial hook on that tooth will increase the anchorage, because you're increasing the number of the teeth to do more distalization. Because if you're using the class 2 elastics to the 6, that means that you have 12 teeth in the lower against the 14 maybe teeth in the upper, because the 7s will be erupted to do distalization. While if you're using the class 2 elastics to the 7s, you increase the number of the teeth in the lower arch against the number in the teeth in the upper arch. So by this, in theory, you get more distalization than mesialization. However, the advantage of extending the elastics into the 7s, that you increase the horizontal vector of the force, so you can get even more proclination of the lower incisors to correct the overjet. Don't forget that class 2 elastics has a vertical vector of the force as well. So here, if you are using class 2 elastics, that will result in extrusion of the incisors and extrusion of the molar, meaning that the occlusal plane will rotate clockwise. The opposite will happen in class 3 maloclusion, which the upper molar will be extruded if you are using class 3 elastics, and the lower incisors as well. So the occlusal plane will rotate in a counterclockwise direction. And this is example of a patient. As you can see here, we have a half unit class 2 molars on both sides and canine. We have an increased overjet. Patient profile is slightly weak. You can do extraction. We can move the lower incisors forward, simply a class 2 elastics, and as you can see, goes from the canine to the 6s, rectangular wire in the upper and lower, finish in a class 1 both sides. Profile of the patient, this is before, this is after. To be honest, it was not really improved. He is not class 1 because we don't grow bone, but at least I did not make him worse, especially if I do extraction in the upper or even distalization and retraction with the prominent nose, as you can see, and slightly weak or increased nasolabial angle. If I do extraction and retraction, his profile will look much worse. So again, these are our treatment options. The last option is always surgery. So if you have a patient like this and the chief complaint of the patient that she doesn't like her chin, she's an adult patient, or if she has a thin biotype or excessively proclined lower incisors, that you can't procline the lower incisor more. So again, let's think here. So patient has a class 2, a mandible is retrognatic. If the patient is not happy with the appearance, then definitely surgery. But if the patient is happy and you're thinking about the camouflage treatment, now you need to check the lower incisors. Can I procline them more? So what do I have to check? I have to check the biotype. Does the biotype able to be proclined? Is it thick biotype? Do we have thick gingiva? And also, what is the amount of the inclination of the incisor at the beginning? So if you have excessively proclined at the beginning, you don't want to procline them even more. So in these cases, if the patient have thin biotype, the incisors are proclined, then the only option to correct this malocclusion is surgery. And as you can see here, just the mandible moved forward by BSSO, and the patient will finish in a good occlusion. Now the last thing to talk about is retention. Now, retention and stability is depending on the lips in these cases. So, in class 2 division 1, if the lips were incompetent before we start the treatment, as we can see here, and then it become competent, that will enhance the stability, because if you reduce the overjet, now the relapse will be by relapsing the overjet, it will be increased again. So if at the beginning of the treatment the upper incisors were not under the control of the lower lip, if you retract them and then you have the lower lip covering the incisal edge of the upper incisors, that means it's bringing the upper incisors into the control of the lower lip, meaning it will prevent the incisors from proclining again. So one of the key points, if at the beginning of the treatment the lips were incompetent and then they become competent after the treatment, that will increase the stability of the treatment. However, if at the beginning of the treatment the lips were competent, keeping them competent will not affect the stability. And also, if you have a patient with lip trap, that the lower lip is trapped behind the upper incisors, after you finish treatment, you have to make sure that the lower lip is not trapped anymore, because if the lip is trapped, the overjet will relapse and we will have an increased overjet one more time. And again, as well, if you have a strap-like lower lip that causing retroclination of the lower incisors, or you have a tongue thrust in which the lower incisors become between the upper and lower incisor touching the lip to achieve anterior oral seal, this has to stop in order to make sure that the relapse will not take place. Thank you very much for listening.